And welcome everybody to today's session. It's always great to be with you. Today is Monday, March the 8th, and this session is about taking your heart medications. I've seen some of you before, but for those of you whom I've not met yet, my name is Paul O. I'm the medical director in the program, and it's always a pleasure and privilege to share a bit of time to talk about topics that are important to all of us. As a reminder for a few of these ground rules that, this is a session for education. If you have a very specific question about your own medications or something else related to your health, that we'd invite you to chat with your own healthcare provider. But we would be very interested in fielding questions. And actually that makes these sessions a whole lot more interesting for all of us. And I'll try to answer those questions perhaps in some general sense. And with this Zoom platform, you'll notice at the bottom of your screen a menu of functions and actions. So we'll invite you to link into the Q&A box right there to ask your question. And I see there is one question already, and I think it relates to a prior session. We're going to come back to that. So stay tuned, stay there, and we'll come back to these questions. But thanks for playing along and inserting some interaction already. The purpose of this talk will be to discuss some common classes of heart medications. Every medicine has some good parts to it. Every medicine potentially has some bad parts to it as well, and we'll talk about those items. And then we'd also just want to remind us about some of the resources that we have available for you to help you manage your medications. And one of the bottom lines here is that if you have a question about a medication, please talk to your doctor, nurse, healthcare provider, and especially your pharmacist about your medications, and get those questions asked specifically. To talk about medicines, and we think that they're important because everybody's taking them. Sometimes, and even in medicine, we learn about medications sometimes as a long list of things. It's sometimes challenging to know, to remember what each of those medicines might be, what's good about them, what's bad about them. Instead, it's helpful if we have a framework about why we might want to even entertain the use of medications in specific scenarios. So I'm going to return for some of you to this image, and for some of you, this might be a new kind of picture. What I'm trying to show you is a framework for why medications might make sense for many of us, that they do have a role alongside all of the excellent interventions around self-management of our lives with exercise, diet, psychosocial health, and self-management. Medicines also have a role in trying to maintain really good health going forward. So this is an image of a coronary plaque, an artery in the heart. Remember, the heart is about the size of your fist, and the arteries of the heart are like the veins on the back of your hand. So think about that. And if you went into that blood vessel and looked inside, we would expect it under healthy conditions to be a wide open tube. So theoretically, the middle of the screen should be blank, and there would just be a wide open tube representing a 100% open artery. This artery has not gone through a happy story. It's had many abnormalities compounded one on top of another over many, many years. The scary parts are shown with these labels. The top arrow refers to this pink crescent-shaped moon-like structure that's in the lower left-hand part of the slide. And that represents a lipid core or cholesterol plaque, or you might hear the terms atherosclerosis or arteriosclerosis to denote this fatty buildup that has been there for years and years or decades and decades. Over top of this fatty plaque, the reason that we get worried about it is that, yes, indeed, it does impinge on the opening of the artery, but it also tends to have very tenuous surface coverings of it, so-called thin fibrous cap. And the cap is prone to rupture. It's like the volcanoes that are active in the world. Every now and again, they're prone to rupture when they get stressed out. And when they rupture, they incite the development of blood clot, or thrombus would be its medical term. And when that happens, that there is a plaque, a rupture, and then thrombus, there is blockage of blood flow. This is what happens in the setting of a heart attack, or again, the medical term, an acute coronary syndrome, heart attack, chest pain, shortness of breath, sweating, arm in the neck, jaw, all of those terrible things that are going on, and blockage of blood flow. Normally, the large opening of this artery is meant to be lined by a beautiful, very pliable, active endothelium lining cell. So blood is meant to flow very nicely through a wide open tube. But instead, we've got all of this terrible stuff going on, and it creates issues for us. So let's go through each of these systems in turn to think about where medications might actually be helpful for us. Let's start with that red internal thrombus part. Think about how blood cells get activated to build up that thrombus, and then think about the medicines that might help in that way. And we'll go through the other systems in turn. And for those of you who are starting to ask questions about medications, hopefully we'll get to the medicines that are on your list that might have impact on this system. So for the blood cell story that makes up that inner thrombus, this is a very largely magnified image of the various blood cells that are available inside of our body. And you'll see that there are these large red ones that are kind of disc-shaped with a central depression in them. And very appropriately, these large red-colored cells are called red blood cells. And their major purpose is to carry oxygen around the body, and to deliver that oxygen to important vital organs like our brain and our heart and our kidneys, and down to exercising muscles so that we can move around. So that's great. As a complement to the red cells, there are these ones. They're kind of purplish in color on this image. On other kinds of microscopic images, they may appear more white in nature. So those ones would have the label of white blood cells. And we know that those are really critical for helping us fight infection and being part of our immune systems. Very important during this time of COVID that we've got good, strong white cells as defenses. And conversely, if we don't have a lot of white cells or dysfunctional white cells, then we may be greater at risk for infection. Okay, the main part on this slide, though, that we want to recognize are these other kinds of cells here. They're kind of yellowish in nature. They almost look like little gobs of glue. And that's an interesting way to think of them, because that's sort of their function, that these little yellowish cells are called platelets. And they indeed are responsible as the sticky parts of our blood system, and provide defense for us when we get injured or have cuts or things like that. That's what the platelet will do. This very detailed blow up of these platelets demonstrates that they have a shape that looks like a pancake or a pita bread. At rest, they can stack up together and then they'll unstack again, like a stack of coins. They're not sticky at rest. In fact, they just kind of move around and bounce off of each other. When the platelets, though, get activated, if they sense that we've been injured in some way, we've developed a cut. If I cut myself shaving this morning, then one of the chemical signals that goes out is locally to the platelets to say that I've been injured. The platelets transform. It's quite a magical thing that you'll see here. It's almost like they go to dance, and they move from the pancake shape. Now they stick out these little fingers or fronds, or in medical terms, these are called glycoprotein 2B3A receptors. So think of them as fingers that go out. You know, if my hands were just fists, I'd never be able to hold hands with anybody. But if I put my fingers out and get them close, now they can grasp. And that's exactly what the platelets are doing here. And you can see they're almost making a ring around the red cells to start forming the clot or the thrombus. When you look at where these kinds of interactions happen, they can happen at sites of injury, like if I cut myself shaving, but they can also happen internally. So if we return to that image of the coronary artery, it's meant to be this big wide open tube. Instead, it's got this kind of crescent-shaped atheromatous plaque with a thin fibrous cap that can be quite irregular in nature. And the issue here is that the platelets, when they're floating by, they may recognize this irregular surface as a site of internal injury, and then therefore try to stick to this place. It can be helpful to a little bit of degree to try to patch up any rough spots. But if a whole lot of sticking happens and the whole clot formation happens, then we may kind of block off this entire artery. And again, that's what happens in the setting of an acute coronary syndrome or myocardial infarction or heart attack. And clearly that's not a good thing. So at this level, microscopically, we're seeing that these platelets get active, stick together, and clump onto those sorts of things. There are also procedures that are done inside of your heart, and maybe a third of you on this call might have undergone a procedure like an angioplasty and a stent insertion. So what's shown here is the artery in longitudinal section. So then here is the atheromatous plaque that was impinging on the artery. What's happened here is that the operator has pushed a wire across that narrowing, inflated a balloon to open up the diameter of the artery from inside outward. And then to keep it open, they are leaving behind this metal strut here. That is what the coronary stent is. While it is a lovely, elegant procedure to open up the arteries, it can also cause a little bit of damage at the very small level of the blood vessel. So when there is damage that occurs, you will know the story. When platelets come along, they like to try to help us with that damage. So they're going to stick in places. So platelets are sticky inherently. When they get activated, they're going to stick more. When there's a coronary plaque, they're going to stick. And when we put in an angioplasty and a stent, they're going to stick a whole lot. So we have to be mindful of this and think about some solutions from the medical side of the house. Okay, so let's understand our friendly platelet even a little bit further. And this is a platelet that's now even blown up further. Now we're going to see inside to what's going on with this platelet. And indeed, we can recognize that there is a lot of chemical machinery that's going on in a platelet. And the idea is that when there are chemical signals to tell a platelet to stick, the signals actually amplify what's going on inside the platelet itself. And the platelet will start to generate even more chemicals to make it sticky. The net effect of all of this stuff, so that there's a whole bunch of chemicals that can signal the platelet, get sticky, start to form little fingers that we saw before. These glycoprotein 2B3A receptors are the fingers of the platelet. When they stick out, they can get close to another platelet. So if we understand that there's chemical signaling that's going on, we can either provide medicines that block the chemical signals from inside the platelet, or block the chemical signals on the outside of the platelet that tell it to stick. Kind of elegant research that's gone on for hundreds of years. We can reduce it down to these couple of minutes of commentary. And I would bet, if I asked you a question in a different way, can you give me an example of a medication that we know, quote, thins the blood? And I would bet most of you are taking a medication called aspirin, and the reason that we take aspirin or ASA or long form acetylsalicylic acid is that it is known to block a key step inside the platelet chemical machinery that prevents the formation of this stuff called thromboxane. Thromboxane, you even look at the word, it has thrombo in it, means it's sticky blood stuff. So by giving a person aspirin, the aspirin makes its way down to the level of the platelet, blocks this chemical reaction, blocks the ability of thromboxane to act on the outside of the platelet to make these fingers. kind of a cool sort of little function. So this is why aspirin will work very well on thinning the blood to a certain degree. And we're very interested that most people living with heart disease take an aspirin because from decades of research, folks have been able to show that people who take an aspirin versus people who don't take aspirin have a substantially lower risk of developing another problem, like another vascular event, a stroke, or another heart attack. And the risk is lowered by about 25% just by taking a little baby aspirin. It's remarkable that such a small little pill can have such a dramatic effect. So really good, but the astute ones of you in the audience who understand some of the medical data will say definitely the orange bar is lower than the pink bar. Definitely aspirin is better than not taking aspirin or taking a matching placebo tablet. But it looks like people in the orange bar are still having vascular events. We haven't eliminated them completely. So why is that? It is because these platelets are darn stubborn. Platelets are like having kids when you're going on a road trip. And for those of you who have children or grandchildren or know of people with children, if you try to take a couple of kids on a long road trip, especially two boys, and you put them in the back seat for some period of time, in the beginning, they might be quite innocent and keep their hands to themselves. But over time, they start to get attracted to one another and start to extend their hands and fingers and start to poke at each other. Look at this interaction. This is like the platelets doing a 2B3A receptor dance here. And then those of you who know how kids behave, you will tell them once, please keep your hands to yourself. And you may say that in a stern voice. And that may work for a little while, that the kids will separate and behave. This is akin to giving platelets and aspirin. But we know over time, the hands are going to come out again and they're going to start to stick to each other. So you have to tell kids not once, but twice, or maybe even more often, please keep your hands to yourself. And the platelets do this same kind of story. So we can tell platelets, don't be sticky. I'm going to give you an aspirin to block this pathway and the thromboxane, but I may need to give you another medicine as well. And this one is called a medicine to block adenosine diphosphate, or ADP. And if I ask you the question again, what medicines might you be taking to, quote, thin your blood? Some of you might tell me that you're taking clopidogrel or ticagrelor or prasugrel as a secondary medication, especially if you had a heart attack or if you had a coronary stent implanted inside your heart, in the artery of your heart, because those are very sticky situations where we need not only one, but probably two different medicines to block two different mechanisms so that the platelets don't stick together. So there is where aspirin is going to work, and this is where the other medications are going to work together. And this is really important because, as we said, especially in the setting of implantation of a coronary stent with some squashing of the plaque against the walls, that this is a situation where the blood can and the platelets can be particularly attracted to the walls and the metal in these arteries. And this is why it's important to take both medications. And often your physicians, especially your interventional cardiologists, will direct you to use the combination of aspirin and one of the other medicines for 6 months and up to 12 months. And if you've demonstrated you're a sticky person from before, that is, you've had a couple of rounds of angioplasty or a couple of rounds of heart attacks, then they might say that we'd like you to stay on combination medication for even longer. Okay, so that was a long discussion about why we are vested into these antiplatelet kinds of medicines. That's the good part about them, that we can reduce substantially the risk of heart attacks, strokes, or clotting that's going on with those stents. But as we said, that there are occasionally bad parts of the medicine as well, and we need to balance those two things. Certainly, if one is taking an aspirin or the combination of aspirin and one of the other medicines, that many of you might tell me that you've developed some bruises, and some of them, the bruises happen when you bump into stuff. Sometimes the bruises happen even spontaneously. What I would like to say is that the minor bruising is quite all right. And you can even think of it as a badge of honor to say, look, I've got a bruise on my arm because I'm taking these medicines. In a way, it kind of shows, if you got a bruise, that the medicines are working. Their intended effect is to make the platelets less sticky. So you might be prone to bruising. And you might note that you might get the occasional minor bleeding, like if I'm shaving myself and I cause a nick, that in the previous times that bleeding would have stopped in a minute or two. Nowadays, if I have the medicines on board, it might take 5 minutes for the bleeding to stop, but it will stop with pressure. Where we need to get concerned is that if there is more severe bleeding that might be happening internally. The risk is there, the risk is small, but we need to be aware of it. And what are the warning signs? Like one of the internal kinds of bleeds that might happen inside of our gastrointestinal tract or our gut is that if there is frank blood that's coming out in our bowel movements, or if our bowel movements turn really dark and black, that's a sign that blood is kind of trickling into our gut, and we have to be aware of that. So these are things to flag to your physician or healthcare provider when you're seeing her or him, and to say, I'm on these medicines. Am I on the right ones? How long do I need to be on them? And I want to do a check-in on bleeding with these medicines. Okay, that's section 1. I hope that was informative, and I'll come back to questions a little bit later on if there are any. Section 2 deals with the notion that the medicines are taken to try to keep our hearts beating safely and effectively. And we can also use medicines in different ways to also help with this system. So where I want to get to is a discussion about medicines that regulate how the beat of the heart goes, the rate and the intensity and the force of the heart. And specifically, we're going to talk about the family of medicines called beta blockers. One of you has already asked the question about certain kinds of beta blockers. To remind you that the beta blockers, we're going to recognize them because they end in LOLs. They're not laugh out loud drugs. They are sometimes very powerful, helpful drugs, but they can also be kind of a nuisance side effect drug as well. We divide these medications chemically on how they interact with certain receptors in the body. These are called beta blockers because they block a receptor that's called a beta receptor. Beta receptors in the heart are kind of like these satellite dishes that are looking for signals. And the signal that they're looking for is a stimulation chemical that activates the beta receptor to make it beat more forcefully and more quickly. These are called beta receptors. So the most common beta blocker drugs that we use selectively block the beta-1 receptor in the heart. Examples of these medications include these ones: atenolol, metoprolol, bisoprolol, but there's a dozen other LOL kinds of drugs in the family, including propranolol, nadolol, timolol, et cetera, et cetera. The reason that we use these ones is that they're common, they've been used for decades, they're inexpensive, they work selectively on the heart. Probably these are the most common ones. And the difference between metoprolol and bisoprolol is that the metoprolol will be characterized by requiring a higher milligram dose. So don't be surprised if you're on metoprolol that you're taking 25 or 50 or 100 or even 200 milligram tablets. Metoprolol acts for a reasonably short period of time. So it might be a good way of starting with the medication while we're getting used to it. So In the hospital setting, where we're unclear about how your heart rate and blood pressure might respond to a new beta blocker medicine, we might give you a little bit of metoprolol just to start things off. And it needs to be taken BID, or that's the Latin term for twice a day. So metoprolol twice a day is typically how it's given. But over the longer term, once you're kind of smoothly established on a beta blocker, we might give you instead a longer acting once a day dose, like a medicine called bisoprolol. And you'll see that the dosing requirements are very different, that this is like 1/10 in terms of the milligram amounts as metoprolol. The milligrams, in my mind, don't matter so much, but it's important we don't confuse them. Both of them are equivalent in terms of their effects on the heart, that slowing of the heart, lowering of blood pressure, that's what goes on. But we tend to use more of this longer acting, smoother medicine while we're kind of out in the community. Why do we use them? Again, coming back to this notion that we're trying to block some hormonal systems, and what is the beta system anyways? Well, a quick digression to talk about why we use medicines like this is that a reminder that we are wired with kind of automatic or autonomic nervous system kind of wiring, that we're prepared for survival. And in particular, the sympathetic nervous system has as one of its chemical messengers adrenaline. And adrenaline, when it gets kicked up in our body, that we're ready to fight something or we're ready to run away from something. So think about the notion that if you were walking out on the paths, going on a trail hike, and you encountered a big bear, well, one of your kind of hormonal responses is to jack up the adrenaline in your body to get you to either fight the bear, which is probably not a good idea, or to run away from the bear cautiously, which might be a better thing to do. Better maybe to back away cautiously and then run while controlling the amount of adrenaline in your body. So adrenaline, we all know the adrenaline feeling of feeling shaky, hyped up, sweaty. And if you look at your heart responses, heart rate goes up, blood pressure goes up. So you're very activated. And that's a good thing in that kind of scary scenario. But some of us have also been through medical issues like this. So if you've had a heart attack or heart surgery and you're lying in a bed, well, this is also a stressful situation where adrenaline levels might be high, and your heart rate is higher than you want it to be, and your blood pressure may be higher than you want it to be. It's not a nice way of actually trying to recover from these events as well. So think about how we might want to use strategies to bring the system down, to calm it down, especially if we're trying to recover from a major cardiac event. So this is where the beta blockers come in, that they work with us to reduce heart rate, HR, and contractility, how forcefully the heart is beating. So we can reduce heart rate, we can reduce blood pressure, and we can reduce the workload of the heart that is kind of related to both of these things. So the system is calmer, we're more relaxed, the heart can heal better. And the net effect of this, when beta blockers are given to people after heart attacks, is that it reduces the chance of having another heart attack. It also reduces the propensity to develop irregular rapid heartbeats or arrhythmia. If you were with me last week, we talked about irregular heartbeats and the role for medicines like beta blockers to calm that down. So good effects of that. The downsides, because again, every medicine has some downsides, is that say on the heart system, cardiovascular system, that beta blockers may cause our hearts to go slow and blood pressure will go down. That's by design, but some of us feel a little bit too slow and blood pressure a little bit too low. We may feel like this little turtle trying to cross the road. And if that happens, if you feel like a turtle, talk about that with your healthcare provider. Sometimes an adjustment of dose or trading one beta blocker for another might make the difference in terms of getting back to feeling a little bit more normal. For people living with asthma, beta blockers sometimes makes the airways a little bit more tighter and can make breathing with asthma more difficult. So be aware of that. If you're living with diabetes, and many of you are, be aware that beta blockers can sometimes blunt our responses to low blood sugar. So if you're feeling that way, that your sugars tend to go low at times, chat with your doc to see if the beta blockers are the best thing for you. And then in terms of brain, some people report feeling overly tired, sleep disturbances, low mood. It's not clear that the beta blockers are directly responsible for all of those things, but it might be worth exploring to see if any adjustments could be made to see if you can feel better. Early on, these side effects may be more prominent. As you get used to the medicines, it tends to get better. So if you're just starting off, stick with it. If you've been on it for a while and you're not feeling right, then do chat about it with your doc. Okay, turning next to this kind of crescent moon stuff and the cholesterol. I recognize we've been talking for a while. We'll go for about another 10 minutes or so. The cholesterol pathway, just to remind us of why medicines for cholesterol might be important. What I'm showing you here is kind of some organs out of context. This is the stomach that is shaped like this kind of bagpipe. This is the esophagus where food comes down. This is the duodenum and intestine where food exits the stomach. And this large kind of duck head shaped organ is the liver. These are the essential organs when we talk about cholesterol. We all are told that thinking about diet is incredibly important when it comes to cholesterol. And indeed, quality, diet composition is very important in thinking about the balance of cholesterol and fats in our system. But interestingly, for the average Canadian who eats a widely varied diet, that only about 25% of the cholesterol that's in our body actually comes from diet. So diet's really important. Quality of diet's important. Diet can affect what happens to us from a heart perspective. But if we really want to affect cholesterol balance, we have to look elsewhere in our bodies. And that's where we turn to the liver and recognize that the liver is actually responsible for 75% of the cholesterol production inside of us. It's interesting, we are wired to make a lot of cholesterol on an ongoing basis, kind of irrespective of what we eat. And the reason for that is that cholesterol by itself is an important essential component to make things in our bodies, like cell membranes and steroid hormones and vitamins. So we can't eliminate cholesterol completely, but because we need some of it, but we can affect a large part of it if we're interested in kind of rebalancing what's going on in our heart and our arteries. And to rebalance a large part of it, we have to work both on diet as well as what's going on inside of our liver. Okay, so then if we understand what the pathway looks like, then we might be able to think about where medications might make sense. You'll see that a lot of medication kind of thinking comes from understanding of pathways or receptors or key steps that we need to kind of influence. So the cholesterol pathway from the liver goes like this, that this liver that's shaped like a duck head takes in various components and then manufactures, turns them over. And there are smaller components called acetyl-CoA and acetoacetyl-CoA that undergo transformation. It's like a factory with an assembly line. These small components are built up on top of each other like Lego blocks to form this intermediate step, to form this larger, more complex molecule that's called cholesterol. Along the way, some really smart folks about 3 decades ago recognized that a key rate limiting step here, it's almost like the essential machine within the factory, is called HMG-CoA reductase. So it was responsible for this key factory step right here. When cholesterol is made, it's in excess. So if we eat as much as we want and our livers are producing as much as we want, then there is a net excess of cholesterol for most of us. And the net excess of cholesterol ends up depositing in places like our coronary arteries. So this is an unhappy situation for many, many people. And this is why some of us have landed visiting the hospital for a heart attack or needing an angioplasty or needing a bypass operation. So the neat thing here is that, again, if you're thinking from the medication perspective and understanding the pathway, that you might think, well, if I block this pathway, if I block this factory, then I might be able to change the cholesterol balance. And indeed, that is what goes on with medicines like statin drugs, because they work basically at this level of the important factory. And the long chemical name for a statin is actually HMG-CoA reductase inhibitor. It blocks this step directly, reduces the amount of cholesterol that's coming out of the liver, and can change the balance of what happens at the level of the coronary artery, because what then will happen is that instead of depositing a whole bunch of cholesterol, what happens now is that the liver can be a withdrawer of cholesterol, because again, the liver is the place where cholesterol is used as building blocks. If it's not making it and you're not eating it, then it's got to pull it away from somewhere else. It's like the cholesterol bank that sits here, it starts to make withdrawals. These are the statin drugs that have been developed over the last several decades. You'll note that we call them statins because the chemical names all end in statin. It's a made up little term. Again, the proper kind of family name for these things is HMG-CoA reductase inhibitors, but that's too long. So instead, we'll just use the name statin. And these last two are the most common ones that we use: atorvastatin and rosuvastatin. These are the older brand names for these. Mostly they're available in generic forms. And the reason that we like these two molecules is that they have the strongest effect on cholesterol lowering, LDL lowering. And the thought is that we need to get about 50% of cholesterol lowered or more to have an appreciable effect on the cholesterol composition in the arteries. And then furthermore, reduction in bad things happening like heart attacks or strokes or other vascular problems. So that's the interesting part about being kind of attuned to cholesterol balance. The new thing in cholesterol kinds of therapies are these injectable agents that are called proprotein convertase subtilisin kexin type 9. That's an impossible name, isn't it? So mostly we're calling these things as PCSK9 injectable therapies, or they're just called cholesterol injection medications. And the way that they work, interestingly, is that at the level of the liver cell, the liver is looking to pull in circulating LDL cholesterol. It pumps out cholesterol, but then it also pulls it back in. And the way that it pulls it back in is by an interaction of the cholesterol kind of particle, LDL particle, interacting with this squiggly thing that's meant to represent an LDL receptor. Under usual conditions, the LDL receptor and LDL particle form a collaboration with these other particles that are floating around that are called this PCSK9, that there is a three-way interaction here that gets internalized into the liver cell. And when the liver cell sees all three components, basically all of it gets broken down inside these kind of recycling depots inside of the liver cell. So in the presence of these PCSK9 particles, the LDL receptors are broken down. You would say, well, that's not very friendly environmentally, and it's also not very friendly from cholesterol metabolism management, because if I could actually recycle LDL receptors, then I can pull in more LDL particles. And indeed, that is what kind of new therapies, that's what the injectables are. So these blue Y-shaped structures represent these PCSK9 inhibitors that are typically injected once or twice a month. If you actually inject these particles, very specifically what they do is attach to these PCSK9 particles. And the net result of that is that there is now only a two-way interaction between the LDL receptor and the LDL particle. When these things get internalized, now at the processing, at the recycling plant, what the body recognizes in these particles is, oh, look, there's only two parts of you. I'm going to take the opportunity to pull out the LDL particle and break it down into its components. But I'm also going to, instead of breaking down the LDL receptor, I'm going to recycle it and send it out to the top. So now I've got more particles sitting on the liver cells ready to grab LDL. And the result of this is that I could lower LDL cholesterol by another 50% on top of what the statins can do for me. So really bring all of this stuff down. So very cool how we are able now to change the balance of cholesterol in a very dramatic way from too much cholesterol from food and production to really dramatically reducing the amount of cholesterol that's floating around. And this improves the health of our arteries. That's the good part. The bad parts are that sometimes we can develop muscle aches and pains related to the medicines, particularly the statin drugs. It's also observed with the other ones, but the other newer agents tend to be taken together with the statin drugs. So it's hard to discern if there's an additional effect or if it's just the statin itself. Nonetheless, we're concerned and watch for certain cholesterol effects. In particular, it's the aches and pains that come up. If it's a statin-related ache and pain versus a regular life ache and pain, the things that I look for are aches and pains that affect big muscles, like the shoulders, the back, the thighs, that last all day long because the medicines are in your system all day long. So if it's related to medicines, you're going to be hurting all the time in the big muscles. And for some people, we might go through some holiday periods. So if we know that the aches and pains started only after you started the medicine, and we together, so you with your doctor, pharmacist, agree, let's go off the medicines for a week or two and see how we feel. Then let's go back on the medicines for a week or two to see how you feel. Then looking for that relationship that the symptoms really start with the medicine, they stop when the medication is stopped, and looking for that kind of pattern. If that's the case, then one can look for alternatives to the statins in particular. And there are a few that are available that can lower cholesterol very effectively. Okay, home stretch here. Last part of the discussion around medicines are medicines that can work on the endothelium, the lining cells of the artery. And we've had a bit of discussion about these sorts of medicines before. That what this cartoon is trying to emphasize is that blood vessels can go through this opening, relaxing part, as well as squeezing parts, or vasoconstriction. And vasoconstriction is important because that's how blood can be pumped through blood vessels, and we can respond to stressors in that way. But there are some people that have hormone systems that are overactive, and in particular, this hormone called angiotensin that might be overactive. And if you actually just look at that word, angio referring to the heart and blood vessels, and tensin referring to tense, there are some people that do this all the time, squeezing fists. So there is too much tension in the system with angiotensin. So if that's happening, you could recognize that blood vessels are not healthy, that they're squeezy in nature. Blood pressure might be high because blood vessels are kind of squeezy in nature. So if we could do something to the angiotensin system in our body, then vessels will relax. Oh, that feels better. My blood flow is better. My blood pressure is lower. This is better. So how do I do this? Well, the medicines that can actually modify angiotensin are called either ACE inhibitors, angiotensin converting enzyme inhibitors, or they may be called angiotensin receptor blockers. Both of them do quite similar things. These ones you're going to recognize because they end in pril. captopril, enalapril, ramipril, lisinopril. You've got the cadence of the prils. These guys are like the cousins to these ones, and they end in sartan, candesartan, irbesartan, olmesartan. They both affect the angiotensin pathway. These guys block the formation of angiotensin. These guys block the action of angiotensin. The net effect, though, is relaxation. And the neat thing is that if you take them under scenarios where the heart's been under stress because of heart attacks, blockages of the artery, or the heart's been stressed out and damaged, so-called heart failure, using these medications can reduce our chance of having a subsequent heart attack or heart failure event. So they are very nice. The bad side of these medicines is that they may cause some dry, irritating cough. If it's a nuisance and actually related to the medication, that it's there at daytime, it's there at nighttime. So if that's an effect, then do chat about it with your doc. About 5% of people will develop a cough like this. Other people with ACE inhibitors or angiotensin receptor blockers, again, because they relax your blood vessels, drop blood pressure. Some people feel like the blood pressure might have gone down a little bit too much. And if you're feeling like you're dizzy, woozy, especially when you're getting out of bed, then talk about it with your doc, and maybe an adjustment might be needed. Okay, wow, we've gone through a lot of information in this last bit of time. That there are medication targets that can address all of these sorts of defects within our arterial systems. We can have medicines that will address this cholesterol plaque, that will address the thrombus formation, that will address the lining cells of the artery and cause relaxation, and that will also kind of relax the overall system of our bodies, and also affect the thrombus and coagulation system. Okay, so that's a lot. If you want to find out more about your own medications, please do take the opportunity to sit down with your pharmacist. And they'll do this on an annual basis with you through a program that's called Meds Check. It's supported through our health insurance system. Sit down with your pharmacist, go over everything that you're taking, what's good, what's bad, what should you be aware of. So if you've never had a Meds Check appointment and you're interested, then do bring that up with your pharmacist. Other kind of helpful hints: that if you are taking your medicines, try to develop a routine with them. Take your medicines as prescribed. Try to stick with the routine. There is a little bit of laxity, like an hour or two on either side. That's quite all right. Try not to stop your medicines abruptly, and talk to your pharmacist about ways to manage your medicine. Some people, for instance, will use something like this, a blister pack that can be packaged by your pharmacist with your physician's assent, or using those little dosette containers to remind you of the days and the times of when to take things. One day, if ever we get back to traveling, then a couple of good hints will be to plan ahead, make sure you've got adequate supply for your trip. If you are taking your medicines on the plane, then take your medicines with you in your carry-on bag rather than checking them into the cargo hold, and carry a list of your medications with your key contacts for your physician and pharmacist, just in case anybody needs to check on that. If you're looking for more reading, then through the Cardiac College website, of course, you can look for the section and the booklet about taking your heart medication. It will go through all of the materials that we've gone through with even a little bit more detail. And if you want to take a video watch, and maybe you've done this in your rehab class, then you may have watched the Take Your Medicine Thrive video, which is really great. Okay, going to jump into your questions now, if I may. And for the medicines in particular, there's a couple of questions about the beta blockers in particular. And hopefully we've talked about the medicines in the category of the selective beta blockers. One was metoprolol. The other one was called bisoprolol. Metoprolol is the one that you'll recognize as higher milligram doses, taken twice a day, shorter acting, so a little bit more fluctuation. Bisoprolol, smaller milligrams, longer action, smoother. So bisoprolol is the one that we typically use for most people in the ambulatory environment, but both medicines do the job in terms of slowing heart down and bringing blood pressure down. What's the best time to take your beta blocker? So for most people, taking the beta blocker in the morning makes the most sense because the heart rates tend to be highest during the daytime, and that's when we might want the most protection. So beta blockers during the morning make sense. At nighttime when we sleep, naturally our heart rates drop already. So taking extra beta blockers right at bedtime may cause excessive slowing of our heartbeats. Of course, if you're on metoprolol, because it's fairly short acting, we do take it morning and kind of early evening, twice a day anyways. A question about beta blockers and heart rate ranges. Is it better for one's heart rate to get to the target range quickly or slowly, and vice versa? So when, if I think that this question might pertain to exercise in particular, and how quickly your heart rates might go up into the heart rate range, we like things to move a little bit more slowly. And that's why the warm-up period of 5 minutes, at least for most individuals, to slowly get the heart rate accommodated is a good idea. We want not only heart rate to go up, but blood flow to be distributed into the right way. So we need to get blood flow, for instance, down to exercising muscles. If we start sprinting right away, then that causes heart rate to go up quickly, blood pressure to go up quickly, and the demand on the heart goes up a little bit too fast. Your muscles may not be able to keep up and get the blood flow that it needs to get established properly. So we try to avoid the quick starts and stops, but move slowly at the beginning. And then similarly at the back end, the cool down period of 5 or 10 minutes is very important to bring heart rate and blood pressure down slowly, get blood flow redistributed to central organs so that we don't cause unnecessary stressors. One final question related to the heart and kind of the electrical system. Maybe a follow-up from our irregular heartbeats story was a question related to something called a bundle branch block. So if you refer to the heart anatomy section of the Cardiac College, how does your heart work, or the sessions about irregular heartbeats, we will have talked about the electrical system in the heart and how electricity moves from the right upper part to the middle of the heart through the AV junction and down through electrical cables or bundles. There are cables that feed the right part of the heart called the right bundle, and there's 2 bundles that feed the left side of the heart called the left anterior bundle and the left posterior bundle. We described that over time that these bundles may develop some wear and tear or short circuits, again akin to the electrical wires in your house, that if you've got electrical cables that are 50 or 60 or 70 years old, sometimes those cables can wear out. If a cable wears out on the right side, the electrical flow is a little bit slower down there, and we call that a bundle branch block. If it happens on the right side of the cables, then that's a right bundle branch block. If it happens on the left side, it's a left bundle branch block. We'll recognize that on the electrocardiogram by the shape of the wave, that instead of a nice, sharp, skinny spike, it may be a little bit wider, representing that electricity is flowing to one side of the heart and then the other side of the heart. So just a little bit of a delay. So that's everything about bundle branch blocks. If you want to find out more about them, we can have a follow-up conversation. And then there might be a couple of questions that are in the chat section. So I'm just looking to that. One question is, can I ever stop using a medication? And the answer is, yeah, sometimes it can be. And it depends on the medicine. If we think about a couple of examples, so if you've had a coronary stent, for instance, and you're using aspirin plus the secondary drug like clopidogrel or ticagrelor, then over time, once the artery heals up and the risk for blockage kind of goes down, then we not uncommonly take away the second medicine. So we'll stay with just an aspirin, for instance. With the beta blockers, the best protection is offered up early in the first year, for instance, after having had a heart attack. Thereafter, the protection from the beta blocker may start to go down. So if your heart rates are okay and your blood pressure is okay, and it's been a long time, or if you've never had a heart attack and you're on a beta blocker, then sometimes you and your cardiologist may decide to drop that one. Statin drugs, we tend to stay on over the long term. Think of it like it took 20 or 30 or 40 or 50 years for cholesterol to build up. So it's going to take a long time to get rid of some of those things. Does the body get used to medications so that doses must rise over time? Not necessarily. Certainly there is some kind of balance that happens with some medications, but once we get to stable doses over a period of weeks to months, then we tend to stay at that. Will diet or lifestyle change the use of aspirin? Typically, the little baby aspirin, we tend to stick with that because it's got a very specific effect on affecting those platelets. And, diet, exercise, while they're helpful, they don't really change the platelet action so much. Our users a risk of aspirin. So what is the risk of aspirin itself? So blood thinning, bruising. Aspirin also might have a little bit of risk of causing ulcers to happen in the stomach. And for that reason, we need to be mindful of stomach pains, the black bowel motions that might indicate that there's bleeding going on. And some of you might have even been offered up stomach protection in the form of an acid-reducing pill like pantoprazole. Sometimes the docs will just get everything as a cocktail to prevent against ulcers that are formed. And then finally, again, back to timing, with the beta blocker question, we said probably the morning is better time to take the beta blocker because that's when heart rates are the fastest. Aspirin, it's less important when you take them, but just take them consistently. Aspirin has a longer duration of action. So sometimes we'll say take it in the morning with your other medicines, when you brush your teeth or with your breakfast, whenever it's convenient and you might remember it. Okay, well, thank you very much for your questions and your participation. That was a lot of material. Hopefully that was useful to you. We'll remind you that there's sessions like this going on every week and invite you to revisit the Cardiac College online website on a regular basis. Look at the live events calendar to see when the next event is coming on. So grateful for you to join us and have a wonderful heart healthy day, and we'll look forward to seeing you again. Take care.